Good afternoon, everyone.
Good afternoon.
When Marie asked me to coordinate this panel discussion, I was very happy to accept. And she has done in the past year. She asked me to give a title to the panel discussion in light of the overarching title for the workshop. So the title I gave to it was, as you see on the outline of our gathering, "The Truth Will Set You Free, Objective Moral Truth and Divine Mercy." The reason why I chose that title is the following. Obviously, in the pontificate of Pope Francis, that the theological reality of divine mercy has been in the forefront. It's almost like a leitmotif of his entire papacy. And it's been, just recently, Pope Francis pointed also to Pope Benedict XVI and to St. John Paul II as his predecessors in promoting divine mercy as a fundamental part of the Christian life. Obviously, when St. John Paul II designated the second Sunday of Easter as Divine Mercy Sunday and actually canonized Mother Faustina as the first saint of the millennium. But I think some difficulty has arisen where people have taken this idea of mercy and have sort of manipulated it to some of their ends, some of which are not ethical. And my concern is this, is that the strength of Roman Catholicism morality is that it teaches an objective morality that's rooted in the natural moral law, which of course is rooted in human nature because we are created in the image and likeness of God. It seems to me that when people have a misunderstanding of anthropology, of the understanding of the human person, we get into a difficulty where their idea of addressing, showing mercy to people becomes problematic. For example, there's some questions that I would like to answer today on transgenderism, which is this phenomenon that has sort of come out of nowhere and has taken off with great prominence, especially, once again, it's the media. If you read the New York Times in their editorial page, the editorial repeatedly in favor of transgenderism. But transgenderism, in my view, and I think the view of the Church, is rooted in a mistaken anthropology. This idea that there is not human nature which determines fundamental issues of morality, what is right, objectively right and wrong. And if human nature does not have a certain truth to it, and if human nature is not understood as the basis for human flourishing, as that nature is lived out in community, then we have a problem. And if we think human nature is malleable and can be sort of fooled around with, then we get into this phenomenon of transgenderism. And people will say that to be merciful, we should support people in this type of transitioning process, often which involves fundamentally immoral activities. So I thought that in our contemporary context, trying to understand that teaching our faithful and people who are of goodwill that Catholic moral realities, that moral truth is not sectarian. We do not believe these things simply because we have some type of private revelation of what it means to be human. That we teach objective moral truth because those truths contribute to human flourishing, to help human beings to be authentically human, and therefore to live in a way that God has intended us to be. So I just want to give that as an overview of the reason why I chose this particular topic. I'll just begin this one question that has, and I don't know whether I pronounce it Reiki in hospitals. The reason why I chose to Reiki, and is that for years now I've been on the doctrine committee of our bishop's conference, and several years ago we issued a document on the Reiki. And the pushback that we received from people across the country, including men and women who were working in Catholic nursing homes and Catholic facilities, they were outraged. They were absolutely outraged. And again, it was a question of a misunderstanding of human nature, in the misunderstanding of how God heals through secondary causes. And it was sort of infused with this preoccupation about, what do we call this, New Age spirituality. And this transfer of powers, it was quite disturbing. But it convinced me that for a generation or two, people of goodwill, Catholics of goodwill, who obviously are involved themselves in a wonderful ministry of the church, Catholic healthcare, but they've so been affected by the culture and these erroneous trends in the culture that are rooted in a mistaken anthropology, that really they have not been taught fundamental Catholic truths about what it means to be human. So I think that we should expect going forward, because we have, as I said, a generation or two of under-catechized people, Catholics, specifically in moral theology and Catholic ethics, that we're going to face these difficulties, and this pushback on Reiki was one of them. And so the doctrine committee's position was this type of therapy should not be conducted in Catholic health facilities.
I do, Bishop. I want to thank you for that. We had a problem already in Washington, D.C. in 1981. We had a homo prayer, and that was being introduced. And at that time, we as a community, I asked the persons who were doing it, on what basis? Is it a massage or basically on the anthropology base? Or what is that? And this sort of the healing touch or allowing some form of other powers, we did not know. He said, I don't know where these powers come from. You're invoking something else that goes beyond, and at that time we were also stopped there. So I was very happy when the bishops gave this very clear doctrinal statement on what that is. So deep appreciation. Okay, I think the question here is for Dr. Shapulski. The question is, how has your practice in medicine changed after the miraculous healing of Barbara? How has your interaction with future patients changed?
Sądzę, że zdecydowanie podejście w codziennej praktyce do pacjenta zmieniło się.
Obviously, this has changed me. My approach to patients, the day-to-day seeing patients, has been modified.
Pacjenci leczeni w oddziale intensywnej terapii są to zawsze pacjenci w stanie średnio ciężkim bądź ciężkim.
Patients in the intensive care are usually in very serious situations, so very grave situations.
Więc stany krytyczne u pacjentów nigdy nie były mi obce.
And so critical condition within patients are not foreign to me, they're strange to me.
Po leczeniu Barbary zauważyłem, że patrzę nieco inaczej na chorobę każdego pacjenta.
After the healing of Barbara, I do look at each person's illness slightly differently.
Mogę powiedzieć, że w niektórych przypadkach modlę się o pomoc w leczeniu danego pacjenta.
I have noticed that when I have serious situations, I am praying for the people right from the start, for my patients.
Jednocześnie zdecydowanie łatwiej, tak mi się wydaje mi się nawiązać bliższy kontakt z rodzinami pacjentów.
What the major change within me is now I am in closer contact with the family of the patients.
Często rozmawiając z rodzinami, czy to z mojej strony, czy ze strony rodziny, dochodzimy do etapu modlitwy, do etapu obecności Boga.
Very quickly, when I am in contact with the family, the topic of God and need for prayer goes right from the starts.
Z kolei mogę chyba też powiedzieć, że w moim prywatnym życiu kontakt z Bogiem stał się głębszy, może więcej treści jest w tym podać.
Also on my personal life of faith, my relationship with the Lord has intensified and on every level. There's one question which I think would be also interesting is regarding the miraculous recovery of Barbara. Did all the doctors, like infectious diseases or pulmonary, acknowledge the miracle, or did anybody try to rationalize the cure, say, attributed her cure to the voriconazole added later in her course?
W naszym zespole jest 7 lekarzy.
In my team there's 7 doctors.
W różnym wieku i sądzę, że też w stopniu zaangażowanych w religię.
And I know that there are different ages and also there are different levels of faith.
Z pewnością troje z nas bezapelacyjnie podpisywało się od początku, od tym wszystkim, o czym żeśmy rozmawiali.
From the beginning, the 3 of us on this team knew exactly what happened, and we put our sign that this is not explainable.
Pytanie jest na temat tego, czy była próba racjonalizacji. Myślę, że chyba na początku tak.
Yes, I can say that for sure that everybody there, perhaps many, tried to rationalize it.
Natomiast po przeanalizowaniu całości dokumentacji już na etapie procesu kanonizacyjnego,
But once we begin to review all the medical records, all the tests, lab work,
po tym momencie nie zauważyłem już prób racjonalizacji, czy pozostałe osoby zostały przekonane, czy też nie zabierają głosu. Trudno mi powiedzieć.
once the process of analysis, analyzing the documentation, no one tried to rationalize because it was quite clear. I do not know the level of faith response on some of them, however, we knew that this was not possible.
Myślę, że wszystkich skłoniło to do głębokiego przemyślenia.
I believe that everybody was forced to a deeper reflection what happened. Regarding the voriconazole, which was added, he says no one questioned that that medicine would do any change. We tried many and nothing worked.
Jakikolwiek powód, czy maszynowy, czy krążenia, czy nerek, czy wydolności.
No one questioned. The reason is that all the aspects of sickness were so severe, and including lungs, which are not possible to replace, no medicine could have changed.
W trakcie leczenia żeśmy konsultowali nasze działanie z Białymstoku. Nic nowego żeśmy się nie dowiedzieli ponad to, co można było wyczytać z piśmów.
We have consulted other clinic, the clinic in Białystok, the good headquarters, and they could not come up with any alternatives.
Woriconazol na pewno nie był tym najważniejszym lekiem, który żeśmy stosowali.
And the voriconazole was not the most important medicine anyhow, which would have brought any change.
Thank you. My question is, the question to me was, living in a secular society where God is out of school and colleges, public medical or nursing schools, how do you think we as healthcare professionals can influence policy and curricula? Well, from one standpoint, as I mentioned, I'm the dean of a Catholic, at a Catholic college, and our School of Nursing, and we live our Catholic identity through our mission. So that being said, we do very much have God and prayer and all of our traditions, our Catholic traditions at my college. But moving into a public sector for which I have led nursing at the Mass Association of Colleges of Nursing, I think the way that we can influence is first to be present and be at the table, seize the opportunity to represent nursing or represent, whether it's your division, your unit, whatever the opportunity, because I do see quite frequently in practice where nurses are not as comfortable stepping out of their role and really taking a leadership role. And then I think through some of the concepts that I mentioned, patient-centered care, compassionate care, that's influencing, I believe, God's work in our practices as healthcare professionals. And the way that, and I have seen influencing policy for, just as we were talking about most of today, about spiritual care of patients and how to introduce that. It's well recognized, whether it's a secular, whether it's a public university or a public medical center, that those are needs of patients and that we treat the whole patient, and it takes leaders to step forward and influence policy in that direction. I hope that answered your question. Maybe someone else can comment.
I agree with Dean Scoble. I think this is the time that we really have to step forward and look at an academic approach in order for us to impact the colleges of nursing, the colleges of medicine, because it seems that there's not a formal program in place, and I know there's several educators in the room here that from our standpoint of working so diligently with healthcare professionals over these past 13 years, what I've seen is that healthcare professionals are hungry to be able to speak about their faith and to share with their patients and do something more. The doctors and nurses that work with Barbara, they weren't there every day because they had to show up. They were really dedicated. And reading some of the Vatican documents and seeing how the nurses and doctors prayed for their patients. And I look at the opportunity that we have now as healthcare professionals to really formulate a program that could be effectively taught in the universities, colleges, across the country. We can really start a specific program that could be well respected and utilized. And I think that's something, Dean Scoble, I agree with. We have to have a program that's utilized, that we just don't have a book and say, okay, this is a good idea. This is how you do it. This is the practical application. And I'm all about the practical application of the Divine Mercy message and devotion. By the same token, we have to actually teach healthcare professionals how to bring up the subject of God. How do we say, go in the room to start an IV? I always used to say, well, how's God treating you today? What's God doing? What's going on in your life? And open that up. I show up with a little Divine Mercy image. I may have my miraculous medal on. Something that gives that patient the invitation to talk to me about faith. But I think what we're talking here is going beyond that. And actually, Bishop, if I could answer one of the questions, do you know of a law similar to the Good Samaritan law to protect healthcare workers that speak of Jesus or faith with patients in an outpatient or inpatient setting? We all know about the Joint Commission guidelines, and where they're very, very brief. It actually empowers the healthcare professional to speak about faith and to investigate further by performing a very brief spiritual assessment, because the Joint Commission requires this as part of the facility's accreditation. So if your director or whoever your supervisor is, or whatever the situation might be, if they're threatening your job by doing this, you report them to the Joint Commission, and their funding can actually be cut off. And this is very powerful. In my own, in the greater parishes here, I was at St. Anne's Parish one weekend at the shrine for a mass, and I heard the priest saying, the pastor there saying, well, if you go to the hospital, be sure to call us, because now with all the HIPAA regulations, they're not telling us who's Catholic, and they're prohibiting us from just going in and finding out. And so after the mass, I went up and I said, Father, I'm going to send you all the information on the Joint Commission and how they are requiring pastoral care and the availability of spiritual care of the patient. So I gave him all the information. He went back and met with some of the medical directors and told them that he was going to contact the Joint Commission. All of a sudden, their demeanor changed. I said, "Oh, Father, how can we help you?" And it literally changed that whole area, how they were going to see patients. So you have the power to do this. You just need to know it's the Joint Commission that protects you.
Okay. I'm an oncologist, so I hope you can answer this one. I hope, but it's not an easy one. But it basically says, how do we continue to have faith when what we pray for doesn't come to pass? For example, when my mother, who loved God, prayed for healing from cancer, she still suffered greatly and died. So I sympathize too, because I take care of a lot, and I'm sure take care of the dying, and with regards to that, still family experiences too. So it is something that I think it doesn't have to be cancer, of course, as we all know that through life, especially those with faith, our goal, of course, is heaven, and our Lord gave us that path, and the pathway He took was the cross, and so it's difficult, it's painful, as any of our crosses are. It's a glimpse of what His was, and so I think with regards to that, and when our Blessed Mother suffered, watching Him go through that, they certainly give us that model to follow by, but it's not an easy path. But with regards to, as I think we've heard as well, that the Lord always answers our prayers. It may not be the way that we intended, but it's always probably far better than what we would have asked for. So, and sometimes we're all going to die in life at some point, and however that happens, only the Lord knows. But to be open to His will and accepting is the big challenge, and it's not an easy walk for any of us, even though we're maybe Catholic and strong faith and devotion. But when we have to come and walk ourselves, we're not alone, we're with Him. But it's very, very hard, and I think sometimes it can be harder for the family members or loved ones as well. So I hope that answers the question, but I sympathize.
Today I talked a little bit about the reward center in the brain and how that cocaine just lit that up, and it was such a strong effect that the body says, "Oh, I want more of that. I like that reward center." So my first comment is a positive affirmation I got to my reward center in the brain, but that encouraged me to maybe write the book on the message of divine mercy and tying it into the 12 steps. But someone asked, can you really start the 12-step work the 12 steps if you're on Suboxone or Methadone? Do they need to wean off to start a real healing process? Well, remember the 12 steps are steps, and it's not an immediate cure. It's a healing, and it takes time. And yes, I think you can start the process, because the key word in all of this is surrender. Ron just talked about faith and trust in God. I'll talk a little bit tomorrow, but what really does trust in God mean? It doesn't mean that everything we pray for we're going to get our answers. But this is not an all or nothing. The 12-step is a process, and it takes time. And as one heals, begins the healing process, the drugs can be weaned, the counseling may continue. There's a Catholic group that are involved in the 12-step that I spoke to their organization a couple years ago, and it's called Calyx, C-A-L-Y-X, and I don't know Latin anymore, but I think that means chalice in Latin. But their whole point is that the healing and the strength comes from frequent reception of the Eucharist and reconciliation in the Catholic faith, so Mass and the sacraments, as well as working the steps. And of course, every day we must put our thumb on our pulse and keep track of how we're doing and be honest, and that whole bit as well. So yes, I can think you can start the healing process. I may ask the bishop for help on this. I'm definitely not a bioethicist. I was a gastroenterologist and scoped and didn't think too much. So, but I'll try and tackle this. I have a problem with when they put a patient in hospice. They schedule morphine around the clock, not as needed. I hold it when the patient is sleeping and not in pain. They look at me as if I'm not normal. comments. Well, I think it goes back to the primary effect and the secondary effect. And what is your primary effect of giving the drug? If you're giving it to take care of pain, then that's okay. And if there's a secondary effect that maybe the patient stops breathing and they're in hospice and they died, that wasn't the primary effect, so you're okay. But if you're giving it when they don't need it, you have to be honest and say, why am I doing this? And if you're really giving it just to help push people over the cliff, then I have a serious problem with that, and I don't think that's what the church teaches. A+, all right. I'll be taking Father Yaverone's talk tomorrow.
In this culture of confusion and relativism, how do we, as healthcare professionals, give truth to patients, especially regarding contraception, gender issues, same-sex attraction, without sacrificing career? I think there's several things here at the same time. On one hand, as you know, ultimately just say, I'm a Catholic healthcare professional, you know that I am against contraception, as you know, and you can say it, and he says, at best I can do is refer you to someone else. Because that means you already gave witness to the truth, and that means you already have said something which probably they did not hear, or they thought was everything's normal. I don't think that you'll be able to sacrifice your career if you say, I'm referring to someone else. Referrals are normal in every profession. I am not able to handle it because my conscience or my faith, I cannot do it. I think probably that's the simplest way, where you give the reason. You're not saying, I refer you to somebody else, but you give reason. I can't do it. It's against my conscience or the core belief of who I am as Catholic or Christian. You may not be, I don't think you're in danger of losing your career. So thank you for that question.
I might add that at the present moment, there is a bill in Congress called the Conscience Protection Act, which is going to be the future of which will be very, very important for the Catholic community and for people of faith who are working in the medical field and who have this crisis of conscience. And this particular legislation would be very helpful. But I think we're very naive to think that we don't have many enemies politically organized to undercut that type of bill. But in the last administration, and for a number of years, there has been a frontal attack on the freedom of conscience in our country. And I think that we have to, it just cannot become an issue for the Catholic Church. And at this time, in the legislative history of the nation, I think the Catholic community has to work to form as many alliances as possible with evangelical Protestants, with Orthodox Christians, Orthodox Jews, who basically share the same view of the human person as we do. But we cannot, the Catholic Church will never prevail by itself because we are naive to think that there is not a strong anti-Catholic biases in our country and our culture at the present time. Just as one question that's might be pertinent for the title of our panel discussion, it says, the psychology of doctor-assisted suicide. Why do so many faithful subscribe to the moral propriety of physician-assisted suicide? Well, I think this is a sort of classical example of misplaced mercy, of misunderstanding of mercy, especially in the field of biomedical ethics and in the healthcare professionals. That if you remember, years ago, the community or the movement that was pushing physician-assisted suicide was called the Hemlock Society. And I think they learned from the pro-abortion group that language is very important. And many people in the pro-abortion community and the pro-physician-assisted suicide community realize that you have to get language that is either morally neutral or morally acceptable. So instead of being pro-abortion, they're pro-choice. Instead of being the Hemlock Society, they changed their title to Compassionate Choices. and they've done that with great effect. However, it seems to me that what we have to do, and we did this a couple of years ago here in Massachusetts, there was a referendum for physician-assisted suicide. When it came to the attention of the 4 bishops here in Massachusetts, we realized we had to counter this referendum. We were like 60 points behind in the public opinion polls. And we hired a professional firm that has been very successful in dealing with these types of referenda issues. But they said to us, and they were Catholics, they said the Catholic Church cannot take, in the Commonwealth of Massachusetts, cannot take the forefront role in the fight. But what we did in our parishes, from the 4 archdioceses and 3 dioceses in Massachusetts, we put a full court press on going into our parishes and conducting education about the issue. And that made a huge difference. That when people move from, and this is sort of the paradigm for contemporary Americans making moral choices. It's basically relativistic, or it's emotivist. You know, you could say, well, I base my moral judgments on what I feel passionate about, and I feel passionate about the fact that people should not have to suffer in their sickness. However, when you are able to counter those types of relativistic opinions and motivistic opinions with the teaching of the Church about the dignity of the human person and the inviolability of life, it begins to put the light on in people's minds. So I think very much we have to do a question of re-education of our faithful. And once that happens, I think people will properly respond in the political arena. But fundamentally, it's a question of a misunderstanding of appropriate show of mercy.
Question here, why did Barbara's family choose to pray the novena? Well, they didn't choose. The mother, after hearing that her daughter was dying, that there's nothing else they could do, went to the church. She began to pray and she was crying. And there was, in that church, there was a catechist. She was also organist. And she was a teacher of her daughter. And so she looked up, she recognized her, she walked up to her, she says, we have to pray. And so she was the one who said, we have to pray the novena, and you have to do it today. Bring your family. And so she was the one who encouraged the family, because otherwise they would not know. So as you see, it's a personal faith. Being at the church at that same time, this was for, this is how God works. And so it was a friend, and this catechist, who actually encouraged and pushed her to begin the novena tonight. And he said, bring your family, bring the boyfriend too, so that there will be a group of people praying. So, as you know, that's what happens. And I think the second question is something similar, so I will pass it.
I have probably about 2 or 3 cards that are a similar theme, so I might try to just summarize. But in essence, it has to do with a number of them had to deal with regards to hospice and the elderly and end-of-life care, particularly like about foregoing treatment. I have a family member now who's suffering with dementia, so this is a topic near and dear to my heart. But with regards to care, I think we're obligated to care for people and do the basic things, food and water and things like that. In terms of putting people, do not resuscitate, I think that, again, that's pretty clear at that point. People are not, we sometimes encourage people, they're going to not pursue those extreme measures. They're going to, if you have a condition that's readily reversible, like a pneumonia or something like that, it's I think, reasonable to give, of course, antibiotics, but one of the questions says that at that point, is it even reasonable to omit the antibiotics? And I think there again, for centuries, people died at home without getting IV antibiotics, and so it is a little bit, in terms of in terms of, I think that question had to deal with natural death too. So it is, there are families that want everything done for their loved one who has profound dementia, including being on a ventilator, and I think those are sometimes harder questions than should we even do it in the first place. I think a lot of folks and families, if their loved one is suffering from that, are inclined not to put them through, mechanical ventilation and shocking and things that may cause extreme discomfort to get with no long-term prognostic benefits. So it is, I don't know if the one size fits all. I think some people with dementia, like one of the questions alluded to, some people have that for many, many years. Physically, they're great, and they could have dementia for 7, 8 years. And traditionally, when you enroll in hospice, a lot of times people think if there's a 6-month life expectancy, not that someone couldn't go beyond that, but unfortunately, a lot of people enroll in hospice like a day or two before they die, and they don't take advantage of all the benefits sometimes. So there is that 6 months may seem like a long time, but compared to some folks with dementia who are physically well, but mentally are just gradually declining, they may not be appropriate to enroll in hospice right away, but yet there can be some limitations with regards to what interventions you'll do. Classically, with the do not resuscitate orders, there's levels of do not resuscitate. Some people say, I'll do this, but I won't do dialysis, or I won't, So I think in some regards, it's nice to have a well-formed conscience, but also to discuss this amongst the family for one, but also with the healthcare providers to try to, for those who aren't in medicine, to get a sense, are there other complicating issues with the patient's health that may make them more prone to succumb to their illness sooner than it may be, not reasonable to pursue some of those levels of DNR. There's about 3 or 4 cards with some of these thoughts on it, so I'm sorry if I didn't get to every single point, but I want to make sure some of these other questions get answered, but that's the gist of thoughts.
I have one, and I'll summarize it. Why would a loving and forgiving father allow the birth of genetically disabled individuals with abnormalities of multiple systems? And they go on to list basically the whole body. And how can we be able to provide compassionate nursing care with the current trends in medical care, etc.? Well, this is along the same lines as working as a catastrophic injury nurse. People will say to me, well, why did this happen? Why did that happen? Are they going to be able to be saved? And throughout my career, when I was younger, I used to wonder these same questions, why? Now, I tend to say the why did this happen stage is actually over. What we're dealing with now is the reality of the situation. And what God has allowed is for our benefit and the benefit of this person, even though it doesn't seem that way. And I don't think that we should base our medical care, nursing care, any kind of care of the patient on the question of if I had only done this, or if I had only done that, or why did this have to happen to me? And we need to turn towards God and put our faith and trust in Jesus, the divine mercy, and Our Lady, and invoke her Immaculate Conception like St. Stanislaus did continuously. But our role is to actually be faith witnesses to these families. And Dr. Scoble talked about being present. And what Father Seraphin first told me when I was writing the nursing book is that we are the merciful presence of Jesus. So if we take that to heart and realize that our hands are Jesus's hands, our heart is his heart, we are Jesus in the flesh for that patient, it takes on a whole new meaning of patient care. And even though we see babies with terrible disfigurements, with genetic disorders, and I have patients with catastrophic injuries where you really can't recognize them after an injury, it's the same thing. We have to focus on the person and how we can help them. And if the patient or the baby is not aware, then we help the family members. So I think if we refocus and realize we are the merciful presence of Jesus, we're there to help them get through this crisis. And that's that compassionate care. That's why this is so dangerous that society took that on, because it's so misleading the way they're using it. Our compassion as healthcare providers, we are actually suffering with that patient. We're not there just to punch in every day and hang an IV and check out what the ventilator has to say and so forth. We're there. We're heavily involved. We're involved day and night with the families. We're trying to make their life better. And that doesn't come from being just a paycheck. This is our vocation. And remembering that we are Christ's hands and feet, and that we are loving these patients and bringing Christ to them brings on a whole new mission. And in my experience as a healthcare provider, on especially these major cases, I've always depended on the Holy Spirit. I don't have the answer. I don't know anybody that does have all the answers. But to me, the Holy Spirit and trust in Jesus is the answer.
I just, Maria's right on target, but I would just say that we have to have the proper theological context to understand the mysterious and vexing problem of evil. That sometimes I think we have a mixed up notion of how God operates. To be sure that God can intervene at any time in his creation and bring about miracles. But as St. Thomas Aquinas often argued, that His activity in the world is often through secondary causes. He does not immediately intervene into human affairs, even in these great problems. So people, as any priest will tell you, that one of the great crises of faith among our people happens in the face of evil, especially when innocents suffer, when children have these catastrophic diseases. But Maria, I think, put a finger right on it, that it's the healthcare professionals, especially Catholic healthcare professionals in our Catholic healthcare ministries. We say that we are in this business to continue the healing mission of Jesus. And I think we have to look upon ourselves that way and be as expert and well-educated and well-trained so that when we intervene as medical professionals, that we're doing it precisely for the purpose of healing. And sometimes the healing will help people to heal from their crisis of faith. But just to pick up on these, which spoken about a couple of times about palliative care and end-of-life decision-making, there's been a couple of questions about the morality of withholding or withdrawing artificial means of nutrition hydration. For the last 30 years, that has been a major neuralgic issue in the Catholic healthcare community, the Catholic theological community, about whether this always has to be provided, or are there situations under which the provision of that can be withheld, or even if it's begun, whether it can be withdrawn. A great help, theological help for all of us happened shortly before the death of St. John Paul II. I think it was March of 2004. There was a group gathered in Rome of neurologists and people who deal with this issue of end-of-life realities. And the Holy Father addressed them, I think it was just through a written form, because he was quite debilitated by that time, and he said that the fundamental crux of his teaching was that the artificial provision of nutrition and hydration is an ordinary means of medical treatment. That was a point of clarification, because for many of us, the argument was being made that under certain that it was an extraordinary means of medical intervention under certain medical circumstances. But the Pope was very clear in saying that even the artificial provision is an ordinary means of feeding and hydrating a person. He said, in principle, which in theological language means that in principle, it should be provided. However, there would be cases under which the beginning or the withdrawal of artificial provision of nutrition, hydration can morally be justified. But the Holy Father also said in that allocation, we have to be very clear, what is the end, what is the finality of providing nutrition, hydration, even artificially, and it's to keep the person alive. So when that provision artificially of nutrition, hydration is unsuccessful, when the person may be aspirating or cannot ingest or cannot biologically assimilate even that nutrition, hydration that is given intravenously, if that's the case, so it is not keeping the person alive for the long run, so to speak, and when it's also causing more pain, causing the person pain. And Dr. Thatcher got his A+ on moral reflection when he talked about the principle of double effect. And so the intention of withholding or withdrawing artificial nutrition, hydration can never be to bring about the death of the person. If under limited circumstances, nutrition, hydration can be withdrawn or withheld, it has to be that the primary effect is to ease the burden of pain that the person is experiencing. The double effect principle is that it's fundamental to the proper application of the double effect is the intention of the actor. So as I said, if the intention is to bring about the demise of the person, it can never be done. The calculus of benefit and burden is fundamental to the correct application of double effect. If a medical intervention brings about more benefit than burden, then that medical intervention must be used. It's an ordinary means of medical treatment. If, however, under certain dire medical circumstances, if the burden is more, if the burden that is caused by intervention outweighs the benefit that can be achieved, then under those circumstances, it could be an extraordinary means of medical treatment. And the person, himself or herself, or the durable power of attorney agent could make the decision to do that. But it's under very circumscribed types of medical conditions that would lead to that type of moral reflection. It's 4 o'clock. Any more key questions, panelists? Well, thank you very much for your attention.